Hello class, it's Dr. Gillard again. Let's put up the quiz that went with the Spondylolisthesis lecture. Remember, this is week 8, which we weren't able to have class because it was Thanksgiving. This is fall 2015. So here we go. Some of this I think I actually was covered a little bit in week 9, but let's put it up here anyway because this is fair game for the final. All right, name these parts. And I'll let you pause, and then we'll go over these kind of as we go through this. All right, let's go through these. So this is the L3 disc. Let's start with this thing. It's not numbered, but what is that? It's the thecal sac. Okay, what about this? I could tag that. Okay, that's a dorsal root. You can call that the exiting nerve root or the dorsal root ganglia of L3. What about this space right here? I could put a tag in this. By the way, is this a T1 weighted or T2 weighted? T1 weighted, right? You can't see the cerebrospinal fluid. T1 weighting shows up fat quite nicely. So this is all fat. So this, oh, it is tagged here, 5. This is the intervertebral foramen, aka neural foramen. Foramina is plural. All right, let's stay in order though. So number 1 is the superior articular process or inferior articular process. It's the superior articular process of the L2 vertebra. It's coming up from below, right? How about number 3 here? That's the inferior articular process of the L3 level, the same level, right? How about 1 and 2 together makes up the L3/4 facet joint. So L4 superior articular facet, L3 inferior articular facet, L3/4 facet joint or zygapophyseal joint or Z joint. In North America we call it the facet joint, even though it's a horrible name. I won't go into that digression again, but okay, so what do we have here? Number 7, just a thin strip of bone. That's the pars intraarticularis of L3. How about number 3 here? This piece, all of this. Good, that's the lamina. This is the lamina. Number 4, spinous process, which actually comes all the way to the back here. This is all spinous process. Makes up the back of the vertebral canal. Number 5 we did neural foramen. You could call it the L3 neural foramen, preferably. Some call it the L3/4, but it's probably, even though it's made by both parts, I would call it the L3 neural foramen or IVF. 6, what about 6? That V-shaped, all this tissue right here. Not this is the lamina. That's ligamentum flavum. Good. Some of that's labeled for you. Let's do the next one. So what's the diagnosis here? You don't even need any history to see this. First of all, what type of imaging? Is it a radiograph, x-ray, CT? Yeah, it's just a run-of-the-mill CT, thin slice. Is it a parasagittal or a sagittal? That could be a test question. Because these are easy ones, right? This is a parasagittal because we can see the pedicle. If it was a mid-sagittal, slice right down the middle, you would not see the posterior arch at all. What do you see? Well, what's this? There's the superior articular process again of L4. There's the inferior articular process of L3. There's a facet joint, 3/4 facet joint. Okay, so here's the inferior articular process of 4, superior articular process of 5. This is all the facet joint. So what's in between the superior articular process and the inferior articular process? And to me, it always seems to hug, the defect always seems to hug the superior articular process, even though none of the literature seems that, or says that, but it sure looks like it to me. Okay, that's a spondylolysis, or is it a spondylolisthesis? No, it's a spondylolysis. Spondylolysis, a fracture of the pars. I prefer you not to say pars fracture. I prefer you to say spondylolysis of L4. Why is it not a spondylolisthesis? Well, look at the corners of the vertebral bodies are right in line. Okay, so that's a spondylolysis of L4. Now here's a new question for you. Typically classes don't do very good with this, but okay, true or false? You can see both. That should be you can see both pars intraarticulari. So you can see the right and left pars is fractured in this view. Never thought of that one, did you? Give you a second to think about that. Both of the parses are fractured. You can see. In other words, well, all right, let's go over the answer here. You can't. Remember, now this is different from radiograph. This is a slice. We have different slices. This is a very thin slice. So this is either the right or the left pars intraarticularis. That's not both. These are not like an X-ray, all in an X-ray, all the slices are superimposed. Remember, I said it's like getting run over by a steamroller. But this is just one pars intraarticularis. I'm not sure which one it is. We would need the axial to know which one it is. What are two related diagnoses here? The key is related. Got a 58-year-old female experienced moderate to severe low back pain following a vomiting episode. I don't care about, just ignore the hyperlordosis and the obvious. What are these things? Surgical staples, probably her gallbladder removed. There's one down here. Might even be the abdominal aortic aneurysm was removed or taken care of here. Hard to tell again without the axial, but what is the diagnosis? Two of them. They've got to be related. All right, here's the answer. Well, what's this? It's the sacrum. L5 vertebral body, spinous. L4 looks pretty good. L3 kind of thin looking, isn't it? Like you could barely see the spinous here. It's just not much bone density. So 1, good. Some of you got it. You got these kind of ghost-like lines here making the vertebrae. So this is a severe osteoporosis. How's this body look? Good. I mean, we can all see this, right? So that's a severe compression fracture of, let's count, 5, 4, 3, 2, 1. A severe compression fracture of L1. Now, remember I said in yesterday's lecture, or was it, I guess Thursday, 2 days ago lecture, what would happen if we saw the same picture, but we had multiple compression fractures? What's a differential diagnosis? If all of these are compressed. Remember, what can cause osteoporosis and multiple compression fractures? Remember I showed you that skull with the punched out lesions? So multiple myeloma can do that as well. But here we just have one. So that's the diagnosis. Severe osteoporosis with compression fracture of, I forgot what it was already, 5, 4, 3, 2, 1 of the L1 vertebral body. That would be the correct answer. Okay, so what type of imaging do we have here? It's actually quite nice. Nice image. Is it a CT? Is it an MRI? It's definitely not an MRI. No, it's not a CT because we can see three-dimensionality here. It's got to be a radiograph. So this is a radiographic image. Now, let me give you a second to make a couple of diagnoses here. This could be your typical patient. Your 4 o'clock patient just came in with low back pain, chronic low back pain. So what do we see? What's the most alarming? All right, let's go through it. Well, let's check the alignment here first of all. Okay, these corners look pretty good. I could draw a line here. So here, this doesn't look so good, right? There's the corner of L5 would be about here, where the cortices come together. This is back here, so we got a retrolesthesis here, or do we? Because we have to go look at this corner to see, and here we have obviously a slip. I would follow the sacral canal up. The back corner should be right here. So we have a grade 1 spondylolisthesis, which is associated with a nice. You guys saw it? Okay, so that's a spondylolysis. Okay, so grade 1 spondylolisthesis with associated spondylolysis, or this is the infamous spondylolytic spondylolisthesis, if you will. All right, now here's the question. Oh, we also have what here? How's the disc space height looking? Looks pretty good. Looks nice. Okay, we obviously have a loss of disc space height. You can call that discopathy, or decreased disc space, I think is more common these days. Decreased disc height of L5/S1. But here's the question. Oh, by the way, what's that? Is that a tumor? No, there's no rim around it. That's just a gas bubble. If you were ever worried about that, you could confirm that by looking at. Well, I guess, yeah, there would be an A to P. That's why we do take an A to P. You'll see that's gas. So the $64,000 question is, which pars interarticularis is this? Is it the left? Is it the right? Is it both? Or can't you really tell? Well, now this time, unlike the CT, these images are smashed flat, like with the steamroller. Okay, so the pars interarticulari are superimposed. So this is a pretty darn big defect. So although we can't tell for sure without a CT, I think it's pretty safe to say this is a bilateral defect because the lucency is so thick. You see anything else here? Is this a long-term process, or is this something that just happened a few days ago? Well, look at the sclerosis here. So we have reactive sclerosis on each side of the fracture. So this is something that's been going on for a while. Okay, next one. So here we have a 62-year-old diabetic male with moderate low back pain, which has come on over the last 6 weeks without incident of injury. Past history reveals he has never had a problem with his back before. He did undergo a cervical epidural steroid injection about 8 weeks ago. What's a tentative or working diagnosis? You can just put that forth right now. I know it's not the greatest image, but these are kind of hard to find sometimes. Good, some of you got it, and let's go through it. So this is what kind of image? Well, we see three-dimensionality here. We can see both sides of the end plate. A CT would not do that. So this is a radiograph or an x-ray. Okay, bone density looks decent. Okay, the end plates here, that looks pretty good. Just a grainy x-ray. And sometimes it's good to look at these, because if you are going to become a DACBR ever, or just be really sharp at reading your own x-rays and not need a DACBR, it's good. These are typical chiropractic x-rays. Sometimes they're not very good. Alright, how's this end plate look? Okay, we got a problem here. All right, now that's not rat bite erosion. You can, that doesn't look good. We got blurriness here. So blurriness of the end plate. Okay, I don't see anything else, but there's a little slip here too, right? I don't see fracture. I do see a little reactive sclerosis here and here. So this is probably a healed pars fracture here, grade 1 spondylolisthesis, but I'm very concerned about this blurred joint space. The fact that the patient is diabetic, okay, that increases the chances for this diagnosis. This greatly increases the chances for the diagnosis. Cervical, so he had a procedure done. Good. So this is a possible infection, an osteomyelitis of the spine uh, versus discitis. Usually the two go together. So not a good thing. Off to the hospital this person goes immediately. Let's try another one. So what's the diagnosis? Patient with chronic low back pain. Let's get this taken care of right now. Is this an old or young patient? Old or young patient? Good. You see the riser sign, so this is teenager. All right, chronic low back pain, athlete. All right, let's take a look at this. Maybe I blew this up here a little bit. Well, this is probably fine. All right, let's look at L4, pedicle. What's this? Pedicle, what's this? Transverse process. What's this? Spinous process. Okay, now what's going on here? L5's, we got some funkiness going on here, right? So we got a cleft here in the spinous. What's that called? Spina bifida. It also looks like another one here where you can't really see. I would never ask you that. All right, what's going on here? Good, we have reactive sclerosis. Reactive sclerosis, you can even see a line lucency through here. See, it's not as white, so that's a spondylolysis. Without the lateral, we can't tell if there's a slip or not. Over here, now this may be compensatory reactive sclerosis because the biomechanics are all screwed up, or it could be a healed, or it may be a new subtle spondylolysis on this side. Remember, it's quite rare for you to have a unilateral spondylolysis. In other words, the fracture site usually is on both sides. There's another picture of it. Let's do another one. What's the diagnosis? We have an 18-year-old American football player. He's 1 year status post a career-ending bilateral spondylolysis. He continues to have minor residual low back pain, which is aggravated by strenuous activity. He's come into your practice. He's given up football, just too much pain. But now he's still having trouble sitting in class, can't play flag football, he just can't do a lot of things. So he brings him with him. Well, you tell me, first of all, what image do we have here? Is this a radiograph, an x-ray? No, we don't have axial views on radiograph. It's got to be a CT, right? It's a CT. Is it a CT myelogram? No, can't see any of this material here. Right, this would be all we'd be able to see the thecal sac if the thecal sac was lit up with contrast being injected into it. It's just a thin slice CT. What do you see? What level is it, by the way? We're not used to seeing this. I think I had one lecture with you about talking about the different views. Is this the typical view we're looking at? No, right? Typically we're looking at the IVF here. So now we're looking above the IVF through the pedicle. So this is the pedicle of the bone. I think this is L4, turned out to be. All right, let's get right to it. So what do we got here? It don't really see, I mean, you might be able to hallucinate a little fracture here, but this is obviously, this fracture is obviously would have been in here. So this is healed, right? So this patient healed. This might even be a little elongated as well. This looks a little long to me. So this was an isthmic spondylo, or isthmic, could have been spondylolisthesis. We need the x-ray, but this was a bilateral pars fracture that is actually healed. Now, if he continues to have trouble, and you maybe try some treatment, I wouldn't do a grade 5 manipulation, but I'm pretty conservative when it comes to that. You don't want to fracture this for goodness sakes. There's a lot of other techniques you can use. Work on the core. You can use some SOT, some activator. There's other things that we can do to get those facets going besides blasting him with a grade 5 manipulation here. But if he just keeps having pain and pain and pain, you might have to order what? I mean, if it becomes debilitating where he can't even go to school anymore, what's the ultimate? No, not an MRI. Some radiologists claim you can see more, but I'm just not convinced. The gold standard would be a bone scan. Bone scan would show if there is osteoblasts are ramped up and trying to fix something that we just can't see here. So you guys know how a bone scan works, right? Radioactive tracers are injected into your blood, and these tracers target osteoblasts. And if there's a fracture here and the body's called into action a whole bunch of osteoblasts, it'll show up as a hot spot here. Let's do another one. 62-year-old with chronic low back pain, 5'10". What's that mean? Is that he's 5 feet 10 inches? No, that's just shorthand. He's got 5 out of 10. So his numeric rating scale, they used to call it a visual analog scale. Now the proper terminology is numeric rating scale is 5 on a 10 scale. So 2 weeks ago he suffered this severe radiating lower extremity pain, severe radicular pain, which ends in the left lateral foot. So that's a semi-clue, right? Or I should be quiet. Let's let you figure this out. So this is the only cut that you get. What's the diagnosis? All right, let's take a look at it. Again, kind of a grainy picture, but there's the L3. Oops. There's the L3 vertebra. Disc looks nice and plump. Looks good. It's a T2 weighted, I can see. You can still see some white here. Cerebrospinal fluid. Disc is good. These discs are degenerated, so he's got degenerative disc disease. This disc space, how's this one looking? Bad, right? It's collapsed. So this is pretty severe degenerative disc disease. If you look closely, you can see some whiteness here. So he's got what? Was this whiteness? Here's some more increased whiteness. You have to look close. This is all increased whiteness. So he's got modic changes on top of that. Alright, so let's look in the back here. Make sure there's no bump sticking out, and we can already see, so he's got at least a protrusion here. Now, do we know that this is a protrusion for sure? Not really. You really need to see the axial, or we need to see more cuts, because it may look like this in the next cut, in the next cut, in the next cut. If it looks like this in all the cuts, it's not a herniation. It's just a general outpouching of the back of the disc. So that would be a disc bulge. How about, let's go down and take a look at this one. Disc space doesn't look too bad. Yeah, now we can see we got a big bump here. So that, it's actually migrated. This is not a disc bulge. I can tell you right now. How do I know? Because the disc herniation material has actually migrated up behind the body of L5. It should not. This should not. If it was a bulging disc, it would not be here. So this is an extrusion versus almost a sequestration. I could hallucinate a little line in here, but we'll call it an extrusion for now because it's big. So the nerve root, the L4 exiting nerve root would be here. The L5 nerve root, look where it is. It's pushed way up to the top. Now it's not getting hammered too bad in this image, but it's undoubtedly some compression, some irritation here. Now, did anybody catch anything else? Well, I know there's a biomechanical problem, but I'm not thinking about that. Well, let's look. This is the par right here. Here's a superior articular facet, inferior articular facet. So that means the pars is right between in this region. That one's okay. So here's a superior articular facet, inferior articular facet. I'm sorry, inferior articular process, superior articular process. So the pars is right here. Nice. Some of you got it. So we have a big pars defect right here. And it has allowed for a little slip. So we have a spondylolytic grade 1 spondylolisthesis. You can say grade 1 spondylolisthesis with associated spondylolysis, or you can say the infamous spondylolytic spondylolisthesis. What type of spondylo is this? This is what I would prefer you'd say. This is an isthmic spondylolisthesis. If you tell me it's an isthmic spondylolisthesis, it's assumed there's a spondylolysis, so you don't have to say all that stuff. So we have an isthmic spondylolisthesis here, grade 1 at L5, with complicated by it's probably a 6, 7, maybe 8 millimeter disc extrusion. One more thing, look closely. What else can we see? Let's look back at the fracture site. What's all this? All right, so that might be, okay, it could be a little bit of the facet or the capsule and ligamentum flavum bulging out, or it could actually be pannus formation, P-A-N-S, pannus formation that has, remember we talked about the beak of the spondylo? So this would kind of be covering the beak. And if you ever fix this surgically, you have to remove all this tissue in order to get bleeding bone. You need bone on bone to when you fuse this thing, you got to remove all this junk. Okay, so we got that one. But for those of you who are biomechanically inclined, what happens if we drop Ferguson's line here? Put some X's through here, drop it down. It should fall through where? It should fall through this part, the anterior 1/3 of the sacral base here, and it doesn't. So we have some anterior weight bearing. It's not severe though. Okay, let's do another one. Speaking of biomechanical, what are two biomechanically related diagnoses here? Okay, same thing. Ferguson's line, you can just drop it right down. So this is more severe, anterior weight bearing. What did I say, anterior weight bearing? What effect does that have on L5? It overloads the posterior arch and the disc. You got a wicked shear force here on the disc that shouldn't be there. What's this, by the way? So not only do you have anterior weight bearing here, what's this thing called? Remember that sacral base angle? There's a bunch of AKs. I think Ferguson's angle as well. This is way, way too steep. Should be about 40 degrees. So way too steep. So what else do we have going on here? Good. We have a spondylo, right? Grade 1 spondylo. Looks like there's a fracture through here or some funkiness. So it's isthmic spondylolisthesis. Okay. What's this? Nice Schmorl's node here, nice Schmorl's node there. Okay, anybody else? What about the size of this? It's kind of tiny vertebral body here, isn't it? So it's a hypoplastic vertebral body. So we get this might be some anomalous formation here. But for our purposes, if you see that, it's a isthmic spondylolisthesis. Okay, now what do we have here? This is very strange looking. Definitely not a radiograph. It's not an MRI. Looks like a model. So this is a 3D reformatted CT Very cool, huh? The computer can actually, from all those slices that we took, computer can actually rebuild the whatever it's looking at. And this is obviously the what? Lumbar spine. What kind of view is this? Good. This is a oblique view. You can actually see there's the transverse process. Pedicle would be right here. There's the neck of the Scotty dog. There's the foot. All right. So let's take a look at the pars. If this is the pedicle through here, this is the pars. This one looks fine. Good, you guys got it. So we have at least a unilateral spondylolysis here. At what level? I'm going to get you on that one. Probably a lot of you will get half off. You won't be able to figure it out unless you're watching this. So here's the iliac crest. What do we say? What level is usually at the top of that iliac crest? Approximately. L4 disc space, L4 spinous. So this is L4 right here. This is L4 spondylolysis. L5 is tucked underneath. Typically, it's hidden by the iliac crest there. So we have a 17-year-old male presents with low back pain, especially at night. Pain gradually comes on over the last 3 months and has progressively intensified. NSAIDs or aspirin gives dramatic relief to his pain. So you work up the patient, neurological evaluation is normal. He does have some muscle spasm, range of motion is restricted. And he's got pain on end range, especially to the left. What are some diagnoses here? This is a nice clear x-ray. So you can definitely make a couple differentials. Okay, well, let's look at the whole picture first. How's the straightness of the lumbar spine? And this is obviously a what kind of image? Obviously a radiograph, AP. So we got a scoliosis here. Actually, you could call this a scoliosis because it starts right here. It starts to go to the left of the picture and then it comes back. So that's a slight scoliosis. Okay, let's look at the pedicles here. Always check the pedicles. This one's a little white, but so is this up here, and we're just getting near the edge of the film, so I'm not convinced. I don't see any. It looks exactly the same size. I don't think that's any type of osteoblastic activity there. Here's the eyes and the nose. Here's the eyes and the nose. L1 looks okay. This is T12, right? There's the ribs coming in. T11 looks fine. T10 looks good. T4, I mean these are all L1, L2, L3. L4, what's going on here? Let's see. Here's the eye. Here's this eye. Now this, something strange going on here to me, right? It looks a little weird here. You can see cortices here, which normally you shouldn't. Might be a little blown out, so I'm not 100% sure what's going on there, but that's caught my attention. Now there's something in the history that's really caught my attention, and this is, I believe it was like 80% of people when they come in, they finally come into the doc's office, they note this dramatic, almost miraculous relief of their pain following aspirin. Okay, I got another picture. Let's go to the next picture, but let's do some biomechanics here. Did anybody catch this? Okay, we got facet tropism here, right? Here's a coronal. This one we can actually see the inferior and superior articular process. We can see the facet joint, so you shouldn't be able to see that. So we got facet tropism going on. We also got, some of you caught this as well, we have a spina bifida here. See, that's funky looking. There's a nice S2 spinous, or sacrotubercle here and here. But this is funky, so that's a spina bifida there. Let's go to the next one. Take a look at this. Okay, so that looks normal to me. This does not look normal. It looks like it has cortex extending into it. There's definitely a color difference. So what are we suspecting there? Let's see, I think I have this up. So based on the last class, well, I won't tell you the diagnosis. Based on the last case, what diagnostic test would you order to confirm your suspicions? Okay, so we obviously ordered a bone scan. Now, does this help us? Remember, what did I just say about bone scans? There's many different flavors of them, but this particular one will mark osteoblastic activity. Good, so now we've got an osteoid osteoma, right? That's classic osteoid osteoma. Differential diagnosis. Let's see here. Clinical symptoms. Oh, differential diagnosis was osteoblastoma. So here's just some, they're very similar in presentation. Here's some differences perhaps. Well, this is their similarities. They can be found in the lumbar spine, especially the posterior elements. They're both benign primary tumors of bone. Patients present with low back pain, scoliosis from muscle spasm can cause. Now, in this case, I disagree here. This is not, I don't think this is muscle. Usually we see a listing where the entire spine goes. This to me looks like a real scoliosis, so I'm going to disagree with that. Let's see. So we can have radicular pain. How can we have radicular pain from an osteoid osteoma? Well, if this, remember, the pedicle forms the roof of what? The intervertebral foramen. So if this is expansile and gets bigger and bigger, it can actually compress the exiting nerve root because it collapses the tunnel. Okay, I think we got that. Okay, let's do another one here. So we have a 17-year-old high caliber discus thrower. So great discus thrower. Presents with sports disabling low back pain, which began about 4 weeks ago. Condition has spiraled downhill to the point of disability. Examination reveals diminished extension and a positive Kemp's test. Neurological evaluation was normal. And here's the radiograph that you took that day. All right. Little star usually means that I have another slide coming. But let's work with this. You got the diagnosis yet? Well, let me see if I'm going to give you more information. This just blows it up a little bit. Okay, let's give you the answers here. So this is S1. I helped you out here. So L5, L4. First of all, how's the end plates look? So these are Schmorl's nodes. So this kid, unfortunately, was not dealt a great hand when it came to the genes that create type 1 collagen and type 2 collagen, because we have multiple defects here. In other words, the building blocks that his genes are ordering to be made are not the greatest. So that's interesting. So whenever you see a discus thrower, discus is high rotary type motion, high risk of what? Spondylolysis, spondylolisthesis, especially at this age. So we got to look closely. So let's take a look here. So what do we see? Reactive sclerosis. We have a fracture site right through here. There's no slip. It's pretty deep, so you could probably assume that this is a bilateral spondylolysis without associated slips. Diagnosis L4, spondylolysis with reactive sclerosis. Now let's go down and take a look here. L5, we have sclerosis of this entire region, especially right here, right? That's right in the pars. So this looks like situation where he's fractured it before and it's actually healed. So this might be elongating a little bit. We have a wicked retrolisthesis here though, right? Here's you can see the end plate of S1 circles around here. So we have a big slip right here. So it's a big one. So we got a retrolisthesis. So we have the diagnosis was status post-healed spondylolysis. And now there's one other diagnosis I would tack on there. Rule out instability. Why would I tack that on? Rule out L5S1 instability. Why would I say that? There's no spondylolisthesis. Well, we got to slip backwards. So it shouldn't be slipping. Plus, we have this thing. What's that? That's a beautiful example of a what? Not an osteophyte, a special type of osteophyte. I'd probably give you half credit if you said osteophyte. That's a traction spur. That comes from the disc, Sharpie's fibers of the disc. So something's really, body's trying to stabilize this region, which makes me even more suspicious. This might be unstable. So what do you order? Flexion, extension, lateral bending, x-ray study, weight bearing. If you send this out, make sure they don't put the patient down. This needs to be weight bearing to really magnify any slip going on here. Okay, another one. 22-year-old college wrestler presents with moderate to severe distress, low back pain 6 weeks ago. Examination findings include pain on extension with a positive Kemp's. X-rays were taken in your office, and here they are. Okay, let you look at it. Looks like history's continued, and we won't give any answers away yet. After 6 weeks of conservative care, what's conservative care? Physical therapy, physiotherapy, manipulation, rehabilitation. Patient continued with, so that's for a kid, that's strong low back pain, 710, with pain on extension. Now he's taking, this is after 6 weeks of care, mind you. So how's your care working if this is your patient? He's going downhill because now he's went to the primary. Now he's on Vicodin, right? That's an opioid. That's a strong dose. Usually they're 5 325s. That's a 10 325. Plus he's taking anti-inflammatory, 1800 milligrams. Is that too much? You guys should know that. So it looks like that part of it is back in play again. No, it's not too much. The max is you can take 800 milligrams 4 times a day would be the max. 3200 milligrams. Of course, as chiropractors now, we can't be, they can only take as directed by the bottle. We can't be telling them to take more than the bottle says. So if you want to add an anti-inflammatory into your treatment regime, which is a good idea in my humble opinion, then send them to the physiatrist you work with or the GP you work with. You should have a network of docs, and you should all inter-refer. That's the way multidisciplinary care. The research is very strong on the effectiveness of multidisciplinary care. You should even have a psychologist on board your team if you want to treat people right. Anyway, so do we want to tell you about this nest? No, you're going to do some flexion extension x-rays. Okay, let you look at those. All right, what's the diagnosis? Let's go back, go through this. Here's the answer. All right, so obviously we got something going on here. Now what level is this? There's the iliac crest. L4 is going to be above the iliac. L5 is going to be generally tucked below. So this is L5 we're looking at here. It's the Scotty dog is L5 pedicle. Superior articular process of 5. Okay, here's the inferior articular process, here's the inferior articular process of 5. Superior articular process of S1. Okay, so here's the facet joint. There's the eye, there's the ear, here's the neck. What do you see? Okay, there's some reactive sclerosis there, which may mean an old fracture that's healed. Maybe it's refracturing. We got some sclerosis up here as well. Look at this. So he's got some facet joint degeneration above, maybe even some gapping. There might be some swelling here. How's the neck? Look at the thickness of the neck. This is the L4 Scotty dog neck, which is the pars, normal. How's this neck look? Aha. So this is dysplastic, right? It's way too small. It's hypoplastic with a P, plastic, hypoplastic. Dysplastic is like you could have hyperblastic, hypoblastic. So this is a hypoplastic. So this is a congenital problem, but it's still, so it's going to make this vulnerable to fracture. Now I don't see too much of anything. There might be, if I had this as a DICOM image, I could measure how much this is flexing. Because this, to me, the space between here and here in flexion looks a little greater than the space between here and here. But it's not, I don't think it's over the line. Now the spinous processes, it's too bad I don't have a DICOM image of this. Because look at the space here of these spinuses. Yeah, that almost looks unstable. Remember we talked about angular motion instability? You know, I just noticed this just now. Look at that. That's really fanny. I think that's going to be too much. I'll go. So that would kind of raise a red flag. I definitely would not manipulate this patient for sure with a hypoplastic posterior arch here. You might fracture that thing. But at the bottom, I didn't see any huge translational slip, which was what I was really looking for. All right, so what's the diagnosis? So we have a grade 1 spondylolisthesis. Rule out spondylolysis at L5S1 because I'm not convinced. It looks like past history of spondylolysis here. So if it happens once, it probably will happen again. So rule out spondylolysis. What does that mean, rule out? That means we're going to treat him for 6 weeks, 8 weeks, and if he gets worse, doesn't get any better, then it's time for a what? To rule it out. Bone scan. With regard to the last case, well, there you go. If the pain persisted, what test would you order to make a more solid diagnosis? I kind of blew that one, didn't I? Bone scan. Let's do another one. 66-year-old male with a progressive low back pain. What's that mean? It's getting worse as time passes. It's got bilateral lower extremity pain. 3, what's that? That means it goes all the way past the knee, past the ankle into the foot. He can't walk for more than 2 blocks because of bilateral lower limb pain and heaviness. Okay, do we have more? What's the diagnosis? You better pause it and try to make it here. I'm not sure if I added more. Let's jump ahead and see. Okay, here's another picture. Same story. So what are 2 major diagnoses and their associated sequelae? You know I like that word. What does that mean, sequelae? Their result. Because of this disorder, this stuff happened. Stuff that happens. Sequelae. Stuff that happens because of the disease. All right, let's walk through it. So this is an axial view. Obviously, we got a view through the IVFs. So let's look at the disc. How's that disc look? It's really fat and bulging out. So this is a disc bulge. How's that vertebral canal look? The vertebral foramen in this case, not very good, right? It's very small. So we have central stenosis, severe central stenosis. What is this thing right here? That is the thecal sac all smashed down. What is this stuff? That's just cerebral spinal fluid in the... No, it's not. That's just fat, epidural fat. This thecal sac is smashed into nothing. So how do the lateral recesses, or how the lateral recesses, and how do the intervertebral foramen look? Really bad over here. Bad here as well. So we have severe lateral stenosis. Anybody catch this thing yet? No, we're not talking about the fat in his multifidi muscles, which is something you can work on, right? This is all fat. So he's been sitting around for quite some time. How's the posterior arch look? Some of you have caught this. I think I showed you the same one in class. Well, let's look at here's the inferior articular process. It's here. There's the facet joint. Here's the posterior articular process, or the superior articular process. So these should be right together, although sometimes you get these little sheep horn deformations, hypertrophic bone change here. So it might be that. Let's look at the other side. Here's the superior articular process. My goodness, what has happened? Here's the inferior articular process. Whoa. I don't see anything to indicate spondylolysis. The spars would be here and here. So what's happened? The entire posterior arch has slid forward, right? Here's the bone below, superior articular, if this is L4, this is L5, superior articular process. So this is a slip. So what do we got? Excellent. Degenerative spondylolisthesis. Can you use NSAIDs in someone with a degenerative spondylo? No, you can use. Remember the isthmic spondylolisthesis, if you think it's acute, no NSAIDs because that will inhibit healing. Remember there's an inflammatory process in bony development. New bone formation depends on inflammation. Snuff that out and you are inhibiting healing. But in this case you can use NSAIDs because there's no fracture here. What's these black things? Good. Ligamentum flavum thickening. So this is just a bad situation here. This guy's undoubtedly going to need to be decompressed via, well, at least a decompression, probably interbody fusion. All right, thanks for watching. Remember, all this stuff is fair game for the test, so make sure you watch this as well. All right, good luck on that test. We'll see you in the next video.